Thank you for being here. My name is Margo Edmunds, and I'm a vice president at Academy Health, which, as you may know, is a national nonprofit organization that focuses on health services and health policy research. I'm really happy to be here with you today. Actually, I've been looking forward to this conversation ever since I received the invitation from Dr. Resnick to talk with you about some of the work I've been doing at Academy Health around stakeholder engagement. And that's because I started my career in clinical practice doing behavioral medicine and working with physical therapists in rehabilitation medicine. I don't get many chances to talk about that work, so it's really wonderful to be able to share some of my experiences with all of you today. So here's what I'll be talking about. I'm going to be starting with some background about Academy Health, and then I'm going to talk about two recent projects that I led on stakeholder engagement. One of them is more policy focused on telehealth research, and one is more clinical and patient-centered, and that's on consumer engagement. The first was funded by Kaiser Permanente Institute for Health Policy, and the second was a PCORI Engagement Award, and I'll be talking more about that in a moment. Then I'm going to talk about that work in terms of emerging trends in the policy ecosystem and the technology world, focusing on telehealth in light of the pandemic, and also about access to telehealth and the role of social determinants of health, which some people are beginning to call digital inclusion. So I'll close my remarks today by talking about the implications of these trends and approaches on research for engagement. So I hope that sounds good. So here's a little background about Academy Health. This is a screenshot. We use the phrase moving evidence to action quite a bit. Our purpose is really to translate evidence and research into policy and practice. And I work at the intersection of all three of those areas. If you look across the top nav bar starting on the left under the Academy Health logo, you see that evidence is really paramount here. We also are a membership organization. We have individual members and organizational members, which include a lot of academic programs. We also have professional resources, which include a lot of webinars and trainings and fellowships and other programs that I oversee. We have a series of events that you may be familiar with. Our annual research meeting usually takes place in June. It's been virtual and will be again this year. The National Health Policy Conference is now jointly held with Health Data Palooza, which is an industry-focused conference working with policymakers and researchers. And then in December, we have a joint conference with NIH called Dissemination and Implementation, or DNI. We also do advocacy work in terms of funding for health services research. We have a blog and a really robust communications program. And so I hope if you're not familiar with Academy Health that you'll be interested in finding more about us. Our extramural policies and programs are funded by federal contracts and grants from the Agency for Healthcare Research and Quality, the Assistant Secretary for Planning and Evaluation, CMS, the Office of the National Coordinator for Health IT, National Library of Medicine. We also have quite a bit of funding and work closely with PCORI. We have foundation funding from the Robert Wood Johnson Foundation, Kresge, Milbank, and others. So our work is very cross-cutting. We do environmental scans, evaluations, we manage learning networks, we do technical assistance on data sharing. We're a program office for grants that flow through us. We do some smaller convenings to develop research and policy agendas, which is similar to what the National Academy of Medicine does, if you're familiar with their work. So currently I'm finishing up a project with the American Public Health Association on social determinants of health, which is funded by the Kaiser Permanente Institute for Health Policy, and those papers will be released in the spring of this year. I also have several colleagues who are finishing up a review of the engagement literature for PCORI, and I'll be happy to talk about those with you later on. So that's Academy Health. A little bit about me and my background. As I mentioned earlier, I work at the intersection of research, policy, and practice. I started off in academia at Johns Hopkins. I've worked with nonprofits, including Academy Health and the Institute of Medicine, which is now the National Academy of Medicine. I also spent some time doing health IT in a corporate environment, Booz Allen. My doctoral degree is in human development, which is a multidisciplinary field. We were trained in systems thinking and systems design. And it's also really more along the lines of community clinical psychology with a lifespan approach, multidisciplinary. So after I finished my doctoral work, I went to do a postdoc to get my clinical psychology license. So I received a research and clinical fellowship at Johns Hopkins School of Medicine. And that's where I met my colleagues in the rehab department. Worked particularly with one physical therapist who's now with the National Health Service in England. We saw patients together. We did EMG biofeedback, billed it as neuromuscular reeducation. As a psychologist, there weren't so many codes for me to use, billing codes and procedure codes, but that was really how I got interested in remote monitoring and consumer technology, and that was also my first electronic health record. So after that, I did a postdoc in health policy at Johns Hopkins. I went back later to join the adjunct faculty at Hopkins, teaching health policy and management for about a decade. Joined the Hopkins faculty of the Center for Public Health Preparedness, and that's where I really started getting very interested in interoperability and telehealth, which is the topic for today. Along the way, I got involved with the American Medical Informatics Association, came to Academy Health to oversee the health IT portfolio at the beginning of the Obama administration with the stimulus funding known as high tech. And I began overseeing the Diversity Scholars Program at that time. So those threads are beginning to weave together. I'm now leading a big project for the VA, developing a curriculum and an implementation plan for core competencies in learning health systems, which includes informatics. We're also going to bring an equity lens to that work. So that brings me full circle, really with all of the threads that brought me here today. And again, I really am looking forward to the conversation after the presentation. So first, as I mentioned, I'm going to talk about a research and policy agenda that we developed with funding from the Kaiser Permanente Institute for Health Policy. We convened people from Academy Health who were doing, this was about 5 years ago, who were doing work on health IT. We had people from the American Telemedicine Association. We also had an insurance association, which was kind of an interesting mix. We had about 25 people. We met for a day. The meeting was chaired by Reed Tuckson, who was the incoming president of the American Telemedicine Association at that time, and he's currently a member of the board of Academy Health. So we developed this framework. I'm really interested in data visualization and frameworks, and I think that they're very helpful to develop an infographic like this so that you can talk from it. There are lots of different levels of depth that you can get into. It's really useful for training purposes, but I wanted to just let you know that this framework is based on the Donna-Bedian framework that you may have learned in your policy classes about. On the left-hand side, the policy context or the structure of what we're talking about in terms of the regulatory environment and the policy environment and payment. The middle section here is about the delivery systems, the processes of care, all the influences on the delivery system, and particularly in this case, talking about the different modalities for telehealth. As we'll talk about a little bit later, a lot of the telehealth research is very fragmented, and our goal with this was to develop an overarching framework. And then the outcomes column on the right side, these should look familiar as the kinds of clinical outcomes that we try to achieve in our field. That paper was published in a journal that we founded, that Academy Health founded with funding from AHRQ, the Agency for Healthcare Research and Quality. It was a journal that lasted for about 5 years. It published a lot of very cross-cutting applied research. And so after the article came out in eGEMS, which is listed in the reference section, we got an opportunity to publish in the New England Journal of Medicine. And this was Reed Tuckson working with the American Medical Association, the co-author here, Dr. Hodgkins. The three of us built on the previous telehealth research agenda. And a lot of the purpose of this paper, which was published in 2017 and went through at least 20 revisions, the purpose of this paper was to really help convince clinical providers, physicians primarily, about how important telehealth was. There was a lot of, even just 5 years ago, there was a lot of mistrust about the modalities. There was some concern about using the technology. There was even more concern about reimbursement and payment policies. So this article was published in the New England Journal, and I think has been used, actually has been cited quite a bit as a background, kind of an overview And if you all are interested in that, I can provide that. You don't have to worry with the firewall for New England Journal. So more currently, I think that we've been hearing about telehealth because of the pandemic. We know now that telehealth has saved lives. It's improved access. It's really remarkable for those of us who've been in the field for a while to see how quickly the changes that were instituted by the Center for Medicare and Medicaid Services, CMS, to improve access to care under the pandemic have really taken hold. What everybody says is we're not going back to the way things were before. We're not sure how many of these payment changes that have enabled improved access for patients and continuity of care. Some of these payment changes have also helped in the inpatient setting to preserve PPE. So there are a lot of benefits of changing the payment infrastructure for telehealth. These are some of the changes that were made. This is from an AMA blog recently that was published in August, talking about parity of payment for in-person visits and virtual visits. My provider friends tell me that actually they can spend more time with patients now because they don't have to spend time traveling from their office to different clinics. That may seem trivial, but I think that it helps people focus. And at the end of a clinical encounter, you can do your charting. Everybody has a different approach to that, of course. I think another real benefit was the waived and reduced cost sharing for patients. More services are covered and a lot of the geographic restrictions have been eliminated. Again, this is focusing on physicians, but tremendous benefits, I think, for the delivery system moving forward. So now I'm going to shift to more of a consumer-focused project. This was funded by PCORI, the Patient-Centered Outcomes Research Institute, which was created by the Affordable Care Act, which is also what created what we call Obamacare. This is the formal title. It's called Leveraging Patient-Generated Data to Improve Patient Experience, a Consumer-Driven Research Agenda. So the way that this came about, this is still on the PCORI website, even though the grant ended last March. What I did was I tried to bring together groups of colleagues and friends that I had gotten to know over the years, both through my work in informatics and health IT and my work in health services and health policy research. And this was a group of people, we almost all of us happened to be at the American Medical Informatics Association meeting. And we had lunch together and we decided that it was really important for us to come together as a group to talk about what was most important in the clinical encounter within clinical systems, to talk about shared decision-making really is the core or the heart of what we do in clinical practice. This group was multidisciplinary, also included some patients. Hugo Campos, who was the co-chair, is on the West Coast. He's in the Bay Area. He's a graphic designer. He's also living with a chronic congenital heart condition. He has a device implanted. He was having trouble getting access to his data when his heartbeat became irregular. That made him a very reluctant advocate, but he got involved as a PCORI ambassador and has been just incredibly effective in that role. He was co-chairing this particular group, but he and Kathy Kim, who's an informatics expert at UC Davis, they had been chairing a large PCORNet project in the Bay Area. So they had been working together quite a bit, and we felt that it was really important to have the patient-centered view centered in the project. And so they co-chaired together. Jeff Corcoran is a graphic and user-centered designer based in Texas. He's done a lot of work with workflow redesign. He's worked with corporate environments, community-based organizations. He's also a graphic designer, and you'll see some of his work in a moment. Patricia Franklin is now at Northwestern School of Medicine. She had a lot of funding from ARC to work on patient-reported outcomes, or PROs. So we had people working on the informatics side using the term patient-generated health data. And we had people on the health services research side talking about PROs, or patient-reported outcomes. Sarah Green was then the executive director of the Healthcare Healthcare Systems Research Network. Megan O'Boyle is the mom of a daughter with multiple rare diseases on the autism spectrum, and she had founded a nonprofit She had taught herself informatics in order to keep track of her daughter's medical records and share them with all of the different providers. And her daughter Shannon was getting ready to age out from her pediatrician. She was getting ready to be 18. So Megan brought a lot to the conversation and is fearless and will ask any question of anyone. Carolyn Peterson is a colleague from informatics. She's now an assistant professor at Mayo Clinic, had also been a PCORI ambassador. And Carolyn is a cancer survivor. She was about 20 years old when she had bone cancer and had her right hand amputated. So Carolyn has done very well in the informatics world and is on the Health IT Policy Committee nationally at HHS. So she's really served in a remarkable number of roles. So we had this formal title from PCORI for the grant. We decided to name it something friendlier. We decided to talk about the care experience because that was something that we felt the consumers and patients that we wanted to invite would be more comfortable with than a researchy title. We got together, similar to the telemedicine project I told you about, as a collaborative consensus group. The advisory group worked with us to develop the agenda. We held 2 multi-stakeholder workshops in May of 2019. One was at University of California, Davis, at Kathy Kim's lab, which was amazing. And then we also had one at our office in Washington, DC at Academy Health. So we had 2 face-to-face work groups with the same agenda. They were divided into 4 tracks, which I'll tell you about in a moment. We had about 45 people total, people from the federal government and PCORI. We had people from advocacy organizations, people from independent consumer tracks and caregiving tracks. Also had researchers and policy people, and it was really interesting. Designers, really interesting cross-section. I had a great time doing this. So we had full group sessions where we agreed on the themes and then people would break out into smaller groups. And this format worked really well for us. The consumer leads on our advisory group really felt that the most important way for us to get the message out was not to self-publish, but to try to publish in peer-reviewed journals. So we have 4 papers that are still under review. We also were fortunate enough to present at the AMIA 2020 Virtual Clinic Informatics Conference almost a year ago now. So we have these 4 papers. One track was really doing an evidence review. That was for the researchers, focusing on shared decision-making and person-generated health data, which is still a kind of a hard acronym. We had a second paper that was led by Kathy Kim. I'm sorry, the first paper was led by Pat Franklin, who does the work on PROs. The second topic we called Tools of Engagement. That was about digital evidence using person-generated health data and different modalities. Then we had a paper that was led by Carolyn Peterson and myself about the policy context, particularly around privacy and security. We had Devin McGraw and other national experts, Jeff Smith, who's now at the Office of the National Coordinator, working on that paper. And then we had a 4th paper, which was led by Sarah Green, which was really about how to change the organization and the culture to be more accepting of shared decision-making, regardless of policy changes. We know that there are a lot of educational changes that need to happen in terms of the hierarchical structure of most delivery systems. So those papers have gone through a few layers of, or a few rounds of review. We're still hopeful that we'll eventually get them published. This, however, is a product that we're really very proud of. This is what we presented last year at the AMIA Clinical Informatics Conference. On the lower left-hand side, you see an infographic that was our vision of the clinical encounter. You see 2 people facing each other. And the person who is in the encounter, we were very, it was made very clear to us that patient was not the term to use. We really wanted to be, to promote an equity perspective. And so we talked about people or persons and clinicians to be more inclusive. So the person brings a lot to the clinical encounter in terms of their history, in terms of who's taking care of them, their financials, their health beliefs and health literacy. This is not an exhaustive list. And then on the right-hand side, you see the clinician, everything that could potentially be on the clinician's mind during the clinical encounter. And this white space in between them is what happens during the encounter, the person-generated health data, data from the EHR, any kind of documentation or decision support tools that are built into the EHR, and so forth. So on the lower left, that is Jeff Corcoran's work. On the lower right, this is Hugo Campos's work. And this is a wheel of, you'll see in a moment, I'll be presenting something on the life cycle of engagement research. But the group really felt that it was important to show all of the different aspects of technology in the shared decision-making paradigm. And so this may be a little bit hard to read, but I'd be happy to share it later on. So this again was out of the goal to communicate broadly to different audiences, to have visuals that would be interesting. We also tried to future-proof this so that this was something that could be used, we hope, for future gatherings of this group and future funding. So what I'd like to do at this point is move into a different area, which has been very influenced by, I think, the field of racial disparities, which really, from the Institute of Medicine perspective, the unequal treatment report that came out around 2000, 2001, really created a kind of a national consensus that there were disparities. And we've spent the last, say, 15 years increasing the evidence about the different kinds of disparities that there are by condition, by setting, by racial and ethnic factors, by age, by ability, and many other factors. And I think that this is now really, since we've been talking about telehealth and about the role of consumer technology, it's really important to think about the people who don't have the same kinds of access or who have barriers to access. So this graphic was created by the Pew Research Center. It was published before the pandemic, but it gives you a sense of the distribution of access to technology based on income. And I think it's fairly clear that people who have more financial resources also are more likely to adopt technology and to be able to afford it. And so a lot of the work that's being done now, I think the executive orders that have come out of the Biden administration are talking about literally the broadband, access to broadband as a utility, has been part of the portfolio, as well as making a national commitment to having a different approach to disparities and to making sure that we have a much more equitable and respectful way of dealing with everyone and understanding and anticipating what their needs are going to be when they come to see us in the clinic or when we have a virtual encounter. I think this is my colleague, Dr. Chris Gibbons. He's a physician, has a master's degree in public health. Dr. Gibbons is one of the people who's using the term digital inclusion to talk about bringing together technology infrastructure with clinical encounters with health literacy. I met him through an American Medical Informatics Association policy meeting several years ago. He wrote an invited chapter in a book that I published for an edited book for Springer on consumer informatics and digital health. And I got to know him better there. I think this is one of the most remarkable people I've ever met. So he started off in medicine. He got very interested in preventive medicine because of the death of one of his friends during high school. He went to medical school. He joined the faculty at Johns Hopkins. He was in the public health school as well as the medical school, and was one of the very few people who were interested in health IT 15 years ago, when it was still kind of something that was seen very much as part of the future. Now it's kind of unimaginable to think about not having technology to support us. But Dr. Gibbons is currently, follow him, you may see him quoted in the media. He is somebody who is now working as an innovator at the Federal Communications Commission, which you may be aware is one of the channels for federal funding to build broadband infrastructure. So he has been, as he talks about it, the Federal Communications Commission is mostly engineers and lawyers. So he's been explaining healthcare in that environment. And he's just really a remarkable intellect, but also somebody who's very committed to this work. There are other people who are beginning to do this work in digital inclusion, and there's a National Digital Inclusion Alliance, which I just found out about, which works more at the local government level. But I think that in terms of local broadband, you're going to be seeing a lot of that kind of, those kinds of investments with this administration. So just a word of encouragement for those of you who are not as technology inclined, think about it as a way of kind of improving access to care, and think about how important that is, particularly now when people are still struggling so much with the pandemic and with its after effects. So what I'd like to do now is to try to tie all of these areas together. I mentioned earlier that there are a lot of these life cycle circular diagrams if you do image searches in Google. I thought that this one was nice. Many of them are very linear. I like this because this is talking about stakeholder involvement in research at all the different stages that people can possibly be involved. I think that if you know people who have been involved with PCORI engagement awards, particularly trying to find patient and caregiver input or consumer input, there are lots of different ways to do it. I think that some of the researchers have been on a learning curve to try to understand how to ask research questions that are really relevant to patients and their family members. So if you'll recall, the way that we put together our PCORI Engagement Award on shared decision-making was really very much making sure that we had consumer involvement from the very beginning. And for example, Hugo Campos, the graphic designer with the implant, is also caregiver for his father. So people who have multiple experiences, I think, are able to engage with researchers in a richer way. And certainly you've seen on medical Twitter or other places that patients and consumers are often uncomfortable with technical people or medical people who they perceive as much more educated, and they feel not confident about themselves. And so starting off with asking stakeholders, in this case, consumers and patients, individuals, what they think is important is really the best place to start. So you start with what they're interested in. If you have embedded researchers, such as the Veterans Administration, for example, as you may know, has embedded researchers who work closely with clinical teams, and they co-develop those research topics. So it isn't a researcher coming up with an idea and then taking it to the clinical team to try to convince them that it's important. It's really co-developed. And I think that that's what learning health system philosophy is all about. So conducting the research, a stage where you want to make sure that you're doing it in a way that's respectful, thinking about the autism spectrum, for example, in our meetings, our PCORI meetings was really important. There were a few people that needed particular environments or that were noise sensitive. And so being aware of what you're asking people to do is really important. And a lot of the user experience, usability research has a lot of really good guidance on that. Commenting on draft research results, I think, again, if consumers and patients have been involved since the very beginning, it's much more meaningful to them. Their comments are more in line with what research would be expected to be hearing about. Then tailoring the messages in terms of what your data show, what's important about it, not just clinical significance. I'm sorry, not just statistical significance, but also clinical significance. Then thinking about how you disseminate your information. Is it only in peer-reviewed journals with firewalls? What are some of the other ways? Can you use social media or talks? Or other ways where you can really meet people where they are, apply the research in your own setting, and then begin a kind of a quality improvement loop. So this is one model that I think is helpful in thinking about the stages of stakeholder engagement. I'm not sure whether this link is still live on the AHRQ website, but the Effective Healthcare site of AHRQ is still current. So this is a list that I developed just for talking to you all today to think about where consumer technology is with regard to engagement, and how to think about shared decision-making with the telehealth in a telehealth environment where it's not always face-to-face, where you might be voice only with phones, you may be using video conferencing. There are certainly other modalities in terms of wearable devices that can upload data. This is a very interesting area right now. I think a lot of clinicians are potentially overwhelmed with the volume of data that you think about your pedometer or other data that's continuously streaming. There are no standards yet for how to condense those data into a way that they would be able to be meaningful in the electronic health record. So this is a really emerging area. And for those of you who are students, I would think that this is something that's really going to be accelerating in the next few years. And there will be more funding for it. I think PCORI has been moving in that direction because consumer culture, consumer technology has really been moving in that direction. So I just wanted to remind us, these are kind of a few areas of interest, and I've touched on these throughout this conversation, but I also think that they're really important for the future. The first is ableism. As physical therapists and people in rehab medicine, you're much more sensitive to this than many other audiences, but I think it's really important to think about engagement and all of the different levels of engagement and modalities of engagement that are most respectful, not just to meet the ADA, the American Disabilities Act requirements, but out of respect for the spectrum of abilities in our culture. We're trained, most of us as clinicians are trained to think about language and translation services, to think about health beliefs that are associated with culture or generations, or to think about how you tailor your messages based on somebody's medical condition, whether they're managing a chronic condition, whether it's an acute episode, whether you're in rehab recovering from a stroke or an accident, all of the thinking like a psychologist, all of the underlying concerns that people have are ones that you want to make room for in your clinical encounters. And these are areas that are really, in my view, under-researched, or a lot of the research is scattered through different journals. Some of them are just discipline specific. So again, kind of a pitch for thinking about ways to broaden the audiences and get into more mainstream journals and alternatives to peer-reviewed journals for disseminating your findings. Another area that I think is really important that's beginning to get more recognition, and I believe with the new director of the Office of the National Coordinator for Health IT and HHS, Mickey Tripathi, some of you may know him. He has been in the Boston area for a long time, studied at MIT, and is just really brilliant in terms of understanding the infrastructure and the last mile problems. So thinking about technology literacy and preferences from a human factors perspective, I think the time is now for that. Many of you might have grown up online. For others of you who are learning about technology as you go, and where you're not digital natives, there have been more challenges from the provider side in terms of feeling uncomfortable with the technology. It's not just that you feel like you want to be in a face-to-face encounter, and during the pandemic that hasn't been the case, but just worrying about the technology and whether it's going to work or how you're going to pay for it are concerns. And so these have been largely talked about in the telemedicine community, the American Telemedicine Association. But I hope that for those of you who are interested, that you'll start exploring that. There's some really interesting usability conferences, UX, user experience conferences that you might find of interest. And some of them are based in Boston physically. So after the pandemic, you might be able to go there in person. Another area that I think a lot of people are talking about workflow redesign in terms of telehealth. But I think one area that is really under-researched is about tracking payment modalities with team-based care. So I think that when we talk from the quality improvement side, we talk about teaming arrangements, having people do a consult all at one time rather than having a kind of a hub and spoke model where the patient has to coordinate all of the different providers that they're seeing. Moving into more of a team-based care model, I think, is really a change in culture, as we were talking about earlier, and that's something that's really important to research, look at some different operational models. Again, the VA has really good models of having, they're not in a fee-for-service environment. Everyone is salaried, so I think that they can really experiment with some interesting models of getting people together. But that also happens at Kaiser Permanente, some of the other health systems. So again, thinking as PTs or thinking about members of a team, I hope that you will have the experience to train in teams. That's really the best for the patients. It's certainly much more fun for the providers to feel like they're working together. And it's actually more efficient. So some of the new payment models that are coming out of CMS are experimenting with that. And I hope that in the future, those will track better. As a clinical psychologist, I don't fit into these models. And that's one of the reasons I appreciate having the opportunity to talk to you folks, because I think that those models are really what we mean by patient and client-centered. And then change management, this last item here, is really speaking to the cultural factors, to the hierarchical factors in most medical systems, to the structural racism that leads people to treat each other differently, decisions that are embedded in the system about who is accepted to professional training, who works with whom, who mentors whom, where do you publish, who helps you get your research grants started, who pays attention to you and supports you. All of those factors, which have been described as soft factors, that have been really invisible, I think we need to center in our discussions in the future about really how to improve engagement, because we need to not only think at the level of the individual encounter where you're sitting across from someone or looking at them on the screen, to thinking about them in their environment. If you think back to the infographic with our PCORI project, that was what we were trying to capture, was the notion of really engaging with people as their full selves, as their whole selves, and feeling like they can trust you, and you have the capacity and support from your teams and your colleagues to be able to provide the best care possible. Another area that I think in terms of change management that's going to be important to watch is looking at social determinants of health and screening for people who have food insufficiency or income problems, or they're unhoused, or there are other kinds of issues that have traditionally been just seen as background. Again, with this administration and the executive orders to really promote a much more equitable perspective in terms of how we engage with patients, I think there are going to be a lot of opportunities. And I hope that the opportunities for physical therapists in particular, I think for chronic pain management and for stroke rehabilitation and all of the other areas that you all are trained to do, I really believe that, that in the future, your work will be much more recognized because you are so close to the patients and understand the context in which they live when they're not with you in the encounter. And you are the ones who ask them what happened since last time. You have really important opportunities to engage with people that some other members of the care team may not have. So just to close out here, I think these are some of the themes that we've been talking about. The value of the consumer voice. I don't know whether the acronym person-generated health data is going to catch on, but I think that, as I was just mentioning, racial equity, the role of assistive technologies, which is where your field comes in, I think are really going to be increasingly recognized in the coming years, and will become, I hope, part of the spectrum of the continuum of care and what we think of in terms of standards of care. This area of clinical workflow, supply chain interoperability, I think we've certainly seen during the pandemic, now that we have lots of armchair epidemiologists, but we also have people who understand that supply chain is something that's really important. It happens outside of clinical and medical training. And so we need to partner with people in operations research. It's called different things in different places, but certainly understanding interoperability, or in terms of the flow of information across systems. The systems may not have interfaces, and you need to figure out how to do the information exchange, which is the topic of maybe another conversation. But that's something that for those of you who are interested in informatics, I believe that there's going to be a lot more attention paid to that because of the COVID experience. I mentioned change management. That's the software or the humanware, however you want to think about it. Helping people understand that we can't just do things the way that we've been doing before. Telehealth has been a positive disruptor in that regard. I mentioned the alternative payment models, or APMs, which those of you who are in a policy environment will appreciate, have been springing up all over the country. The way that we deliver care is very regional. So what happens in New England is very dominated by certain providers. Again, that's another conversation, but I think that just to mention that the Center for Medicare and Medicaid Services, we don't know who the director of that, or commissioner administrator of CMS will be, but certainly this administration is really interested in finding ways to do new models that are fiscally responsible, because that's their mission, but also that really get care to the people who need it when they need it and in the way that they need it, and follow up in terms of accountability and reporting that's meaningful. The last point, again, I just wanted to emphasize how important human-centered design thinking is when we move into the future. And I'm reminded when I put these words down that a colleague of mine, Andrew Ibrahim, is a surgeon at University of Michigan. And I met Andrew when he was in medical school, and he interned with me at the Institute of Medicine. He was then a surgeon who was interested in health policy. And I thought, well, that's kind of unusual. Although Chris Gibbons is also a surgeon who's interested in health policy. But then Andrew got interested in architecture and design. And he took a year off from medical school and went to study architecture. And now he's doing all of that. He's doing design of hospital environments, probably some outpatient environments too, that are more human-centered, so that people can, and certainly COVID has really shown us how unfriendly hospital environments are. But I think that this is another area that's really going to be moving forward. Andrew is one of the people who's been pioneering visual abstracts. You may have seen these in some of the journals, and please encourage your journal editors to think about this. Rather than having a text-based abstract, it has an infographic at the beginning of the publication, and you can see what the flow of the information is. You can see how all the big ideas fit together. So it involves different cognitive skills, but I hope that you have an opportunity to study doing design thinking. There are lots of courses springing up. There's several of them online. But again, something that I think will really enrich your clinical experience, and I believe is merging into the policy training stream as well. This is another one of my favorite ideas, that if you really want to engage with people, there's a lot of marketing research that shows that you should have pictures of kids or people or puppies. So this is an Agency for Healthcare Research and Quality funded this outreach. They were finding that people were not taking this pre-diabetes test. They were very concerned about, particularly in Latinx and other communities of color. This ad really increased the uptake of the pre-screening tests. So kids and puppies. Actually, these days, soothing landscapes are also, I think, really appealing. But again, getting away from text, looking at visuals, and engages a different part of the brain. You all certainly understand better than I how important that is. So here are the references and some other resources that I mentioned. The Springer book, I have the cover that I'll show you in a moment. The eGEMS article that I mentioned about the Emergent Research and Policy Framework for Telehealth eGEMS is no longer being published, but the National Library of Medicine picked that up, and so that's available. Chris Gibbons' article with his colleague on consumer health informatics and digital inclusion is here. If you're interested in copies of those chapters, I can provide them. And then the Texan article in Telehealth and the link for the National Digital Inclusion Alliance. Again, I've just learned about them recently, but I think that particularly for those of you who are involved in community-based organizations, that may be a really good resource for you. So this is a plug for the book. It came out in 2019, and I'm happy to answer any questions when we get to the follow-up to this presentation. I just really want to thank you very much for the invitation and hope you have a great day. Thank you.